So I'm going to touch on the topic of transplantation and ACHD. Here are my disclosures. And my biggest disclosure is that I'm not a congenital specialist. I'm an adult heart failure and transplant and MCS physician, but I am embedded in our ACHD program that straddles both Penn, the adult hospital, as well as Children's Hospital. And these are my colleagues listed here that you can see that share my passion for ACHD. When we look at the stages of heart failure, we see that we focus on those who have advanced disease, stage C and D, and that we specialize in those who have refractory heart failure, who have continued severe disease despite maximal medical or surgical therapies. And we know that when an adult heart failure patient is starting to fail, there are some obvious clinical signs that we see: a dropping ejection fraction with some exceptions, restrictive heart disease, HCM, malignant arrhythmias, and cardiac tumors, and that also they have poor functional status, either shown by history, New York Heart Association functional class, or by 6-minute walk or cardiopulmonary stress testing. We'll talk a little bit more about this in a little bit. But we also have other clinical signs of patients who are intolerant to their neurohormonal blockade, recent hospitalizations, need for inotropes, high-dose diuretic regimen, hyponatremia, electrical instability. And these are things that we can watch for as heart failure specialists to see that a patient may be progressing, and we need to evaluate them for advanced therapy such as heart transplant or MCS, mechanical circulatory support. And our guidelines are very clear, almost black and white really, in the heart failure population, that they have poor reserve, poor hemodynamics, pretty straightforward guidelines of not too many comorbidities without significant end organ function for heart alone, needing to have a psychosocial evaluation, noting that they have good support as well as good psychological ability to remain compliant. Malignancy also is a problem, to make sure that they are free of disease, because the immunosuppression can, of course, make this malignancy worse. We also want to make sure that they have non-cardiac disorders that allow them to have a good 5-year prognosis. But what about transplantation and MCS in adult congenital heart disease? This becomes less clear. This was a document by Heather Ross and Karen Stout in Circulation in 2016, which put together a nice algorithm that you see here that we can break down a little more carefully. And so you see here that the congenital heart disease patient with heart failure, what do you start to look for to consider them for advanced therapy such as heart transplant? So worsening symptoms, these may be increased arrhythmias, increased difficulty with volume management, worsening functional status, and in the growing population of failing Fontans, the complications such as PLE, ascites, and plastic bronchitis. And I do depend on my ACHD partners to tell me when all palliative options are exhausted. We also have a dedicated adult electrophysiologist that works with our CHOP electrophysiologist. I do attempt traditional neurohormonal blockade in these patients, and beta blockers, especially if they're having arrhythmias. And we know that sildenafil in the failing Fontan has shown some benefit in exercise performance, both resting and exercise hemodynamics. In terms of biomarkers, NT-proBNP has been shown to have a prognostic value in ACHD patients. It's also been shown to parallel New York Heart Association functional class, where large differences are seen with different cardiac lesions. So we don't have a risk threshold yet per lesion defined. So how else can we evaluate a prognosis in our ACHD patients? Peak VO2 and heart rate, reserve in combination and as a continuum, so trending over time, have been shown to have predict mortality in both cyanotic as well as non-cyanotic ACHD patients. We don't have an absolute dichotomous value like in our acquired heart failure patients, where a peak VO2 of less than 14, if they meet respiratory quotient, is predictive, as well as looking at our younger patients, percent predicted, and the VEVCO2 slope. This was a paper that was beautifully written by Dr. Inuzuka, showing that per cardiac lesion, that there is a continuum of VO2, perhaps leading to our ability to prognosticate these patients better. And you also see from this article that, in summary, a combination of traditional heart failure prognostic risk factors, as you can see from this table: advancing age, arrhythmias, hospitalization, poor functional status, worsening echo, and other biomarkers are shown here. But also be aware that these patients tend to fail quickly and frequently do not have a bailout, such as MCS due to anatomy. So it's not necessarily one specific finding that may lead the ACHD team to refer a patient to transplant, but rather trends in how they're behaving and what these clinical signs are showing us. And this, in combination with a multidisciplinary conversation, will help lead us towards deciding whether a patient is appropriate for transplant. There are other things to consider unique to the ACHD population. We have to understand the risk. There's a survival disadvantage for the ACHD population going to transplant that resides both in the waiting period as well as the perioperative period, and I hope to show that to you. The wait time is longer. Their listing status is lower, so we know that our adult congenitals are disadvantaged in the new listing status. Our patients have multiple prior surgeries and frequently requiring transfusions for those surgeries. So they're frequently highly sensitized, making finding a match much harder. They also may require complex vascular reconstruction and higher risk at the time of surgery due to multiple sternotomies and the presence of collaterals. So we have to say, as transplant cardiologists, please refer early. When you start to see signs of patients having arrhythmias or worsening functional status, it's time to start thinking about it. When we look at heart transplant, we see here that over time, ACHD is a growing population of patients who undergo heart transplant in the adult world. When we look at our outcomes, transplant remains the most effective treatment for advanced end-stage heart failure. And you can see that over the decades, our survival has gotten better over time. And when we look at adult transplants by diagnosis, you see in the yellow that our congenital heart disease patients have an upfront risk perioperatively, but then if they survive the first year, that they have much better outcomes than our other transplant patients based on diagnosis. And also, sometimes just a heart is not enough, that dual organ transplant must be considered. Heart liver, which we'll go more into, heart kidney. Hopkins has shown us that outcomes in dual organ heart kidney are similar to that of heart alone, and heart lung. You can see here in yellow that heart liver has been gaining momentum, and that is an increasing population of patients that we're seeing in the transplant world, and that adult heart lung transplants has decreased over time with congenital heart disease patients in red. So when we look at our Fontan patients, who are our growing population of patients that we are seeing for heart transplant, we focus on the liver and whether or not heart liver should be considered on all of these patients. This was a white paper just published in Circulation just last month with Juliette Emanuele leading this effort, along with some other colleagues also here at Penn. And you can see here that the results of heart transplant for congenital heart disease have, although they've improved over the last 10 years, congenital heart disease continues to be a risk factor for early mortality, that you see that they have a higher mortality rate, on average about 20% hospital mortality for the adult Fontan, compared to about 5% to 10% in the other adult heart failure patients going to transplant. When we look at the outcomes of combined heart-liver transplantation in the failing Fontan, as you can see here in our publication, that in patients of 17 referrals, 7 ultimately went to combined heart-liver transplant. And what we found was that the post-op complications included AKI, 2 out of 7 required short-term dialysis, atrial arrhythmias, bleeding, but our 30-day survival was 100%. And our long-term average 4.6-year survival was also 100%, with 1 rejection in a patient who stopped taking her medications. No cardiac rejection, that was a liver rejection. So what did we learn? That liver biopsy should be done on Fontan patients undergoing heart transplant evaluation. If listed for heart alone, at least annual liver assessments should be performed. As you can see here, laboratory measurements of liver disease were largely normal, but the imaging was abnormal in all of our patients that were listed. All patients had grossly cirrhotic livers on visual inspection intraoperatively, and our transjugular liver biopsy correlated with liver pathology performed at the time of surgery in all patients. So with careful multidisciplinary selection and follow-up, these patients have an excellent mortality with minor morbidities, and their liver does afford immune protection. This is a paper presented by our group in California that looked at, instead of sequential heart-liver from the same donor, on block combined heart-liver transplantation in the failing Fontan. And you can see this was the time frame at Stanford, and that of 37 patients referred, 25 met criteria, and 9 underwent heart-liver transplant. And you can see that they also had 100% 30-day survival. 5 have thus far survived 1 year, 1 mortality due to PTLD, and no cellular or humoral rejection. All 9 livers that were explanted were grossly cirrhotic, and en-bloc surgery showed excellent short-term outcomes. So the proposed mechanisms of immune privilege status is shown here in a publication by one of my colleagues, Juan Ortega, along with my liver colleague. And you can see here that the liver does provide some immune protection for our patients undergoing heart transplant, especially in those who are highly sensitized. The other thing to consider are collaterals. So and you are much more knowledgeable about this, my ACHD colleagues, that collaterals can conform in especially our Fontan patients, AP collaterals, as well as veno to venous collaterals, chest wall collaterals due to prior sternotomy, and these can lead to high risk bleeding risk. So at Penn, we combine our efforts with CHOP, with a congenital radiologist, adult congenital cardiologists and surgeons, transplant cardiologists and surgeons, and we categorize our collaterals by imaging as mild, moderate, or severe. We note whether they're in the surgical field, and will the patient be hypoxic post-operatively. We at Penn do not coil, but we may start entering into that, along with the help from our colleagues at UCLA, Jeanette Lynn, Jamil, and Glenn Van Arsdale, all through personal communication, show that coiling is a possibility, that they have a series of patients, I think they're up to 7 now, and we'll be publishing this soon, that they coiled the collaterals at the time of evaluation, and then every 3 months while they wait in-house for transplant, and with that have decreased the risk of bleeding. in our adult congenital patients. So questions that remain: what is the best way to assess the post-Fontan liver? We suggest imaging, CT or MRI and biopsy, transjugular for us, percutaneous at CHOP. Evaluation for portal hypertension is also important by the VAS criteria, varices, ascites, splenomegaly, and thrombocytopenia. How much liver dysfunction is too much such that concomitant liver transplant is required? We suggest a FibroSure score of 3 or higher, or they have clinical signs of advanced liver disease, or they have frank cirrhosis. If a patient is listed for heart alone, the liver should be reassessed. We suggest imaging or biopsy yearly unless there's a clinical change. Also, if heart liver transplant is to be considered, should the surgical technique be sequential or en bloc? Should the heart liver be considered in highly sensitized congenital patients due to potential immune benefit? This is a big question, that even if their liver isn't quite meeting the criteria for transplant, because of the immune protection it provides, should they be considered for heart liver in a highly sensitized patients? And should collaterals be coiled to decrease the surgical risk? And if so, how often? So in summary, more children with congenital heart disease are surviving to adulthood. It is a complex and heterogeneous population of patients. The timing of referral for a heart failure specialist for consideration for advanced therapies is not yet standardized. And it's important to know that the wait time is typically longer, especially in the new listing era. Therefore, if you start to see your ACHD patient having arrhythmias, a worsening functional status, increasing diuretic requirements, a trend towards a worse VO2, consider referral to your heart failure and transplant specialist. So refer early. Thank you very much.
Excellent presentation, Joyce. I really enjoyed it. I learned a lot in this in these minutes. I'll use a lot of this in our practice. So as said